Hi all, good morning. I'm Dr. Jishnu Janardhanan, your Medico Psychiatry faculty. I hope you guys are doing well. And today we'll be dealing with psychiatry in about 4 to 6 hours. And I will be discussing all the relevant areas. And I've deliberately omitted one area, which is psychology. That is not so beneficial because if you go into the depths of psychology, it will take very large time. That won't be beneficial from an MCQ point of view. And I've inserted many tables that all these tables and notes will be given to you. The link is, that workbook is given in the description. And I request you guys to just respond, be interactive, because you just take it as a practice session. That means you are reading the question and as if you are hitting the answer, as if you are hitting the real exam, I request you to type your answer. Let it roam. Nobody is going to judge you here. Make mistakes here and then make the correct answers during your NEET exam. Okay, so all good to go? Okay, here we go. First question, what is the maximum duration of stay permitted under voluntary admission in a hospital as per Mental Health Care Act 2017? Options, I request you guys to just type in your answer in the comment section. 48 hours, 14 days, 30 days, and 60 days. And the answer is 30 days. So we're dealing with a relatively newer area in psychiatry. So the likelihood of questions from MHCA 2017, Mental Health Care Act 2017 is high. And I'm summarizing the important sections as well as important concepts of MHCA 2017. So what is asked here? What is the maximum time in voluntary admission? So there are many sections which are important. 86, section 86 is voluntary admission. That means if you think you have a mental illness or mental issue which requires admission, you can go and request for admission. And there is no bystander needed for that, and you can discharge whenever you think, demand discharge whenever you think you are okay, right? That is voluntary admission, section 86. Section 87 is admission of minor, and 89, which is an important concept, supported admission. Many times in psychiatry, we will have to admit people who are not willing to get admitted, who are very violent, who are delusional, who are having hallucinations. That means who don't have insight into their illness. In such cases, we use the section 89, supported admission, which means when the patient does not have the capacity to take mental health care decisions. Be it voluntary admission, be it supported admission, it is up to 30 days. Okay. And suppose the patient needs to be treated beyond 30 days, that is supported admission beyond 30 days. That is section 90, supported admission beyond 30 days. Yeah, very good. Swayam Malavya, your answer is correct. 94 is for emergency treatment. And section 95, prohibited procedures, that is chaining. Previously, people used to chain people with mental illness, which is totally unethical and inhuman. That is prohibited. And ECT without anesthesia. Today, what we are giving is modified ECT, which means electroconvulsive therapy, which means ECT under anesthesia. You might have seen depiction of ECT in films. It's not like the whole body will jerk like this and he will be like in a comatose state. It's not so. It's just like any other surgeries, we are giving under general anesthesia, right? Okay. And section 97, restraint and seclusion. Most importantly, section 115, that is decriminalization of suicide attempt. Previously in our law, suicide attempt was considered to be a criminal offense, but now we know that it arises from a wounded soul, right? The person is presumed to have severe stress, and is it right to punish a person who is already in a severe stress? No. That's why we have decriminalized suicide attempt, which is section 115. And the two more concepts, only that much is needed from Mental Health Care Act 2017. What is? One is advanced directive. What is advanced directive? In case of a future in mental illness, suppose I develop a psychiatric disorder in future, I can decide how should I be treated or how should not I be treated. That is advanced directive. So that you can prepare, any person who is not a minor above 18 years of age can prepare advance directive. And what is nominated representative? Suppose you lost that insight, so somebody has to take mental health care decisions for you, right? That person is nominated representative. And in the advance directive, you can mention, in case I lose my insight, I don't have capacity to take mental health decisions, I can I represent this I nominate this person as my nominated representative. That is nominated representative. Okay. But in our situation, practically nobody is going to prepare such a document, right? In case of future mental illness, I should be treated like this. So in that case, by default, the legal relatives becomes the nominated representative. So this is all you need to know about MHCA 2017. Don't read any line further. I can guarantee. Okay. Moving on to the next question. An individual with a non-psychiatric disorder on treatment and is not a minor can choose to decide the caretaker and the course of treatment according to Mental Health Care Act. This is called, what we have discussed already, that is advance directive. Which of the following is a cause of delirium tremens in alcoholics? Options are, remember, take it like a practice, shoot your answers. Fatty liver, acute infection, gradual withdrawal of alcohol, and small doses of consumption. Which is the answer? I can wait for 5 seconds if somebody is going to type the answer. Okay, not even Swayam Malavia is typing. So I will just give the answer. And the answer is acute infection, right? So we are dealing with a most important topic, which is alcohol related conditions, alcohol withdrawal delirium, which is also called delirium tremens. Okay, delirium tremens means alcohol withdrawal delirium. In addition to that, we have autonomic hyperactivity, which is a hallmark of delirium tremens, right? And the MCQs, I have just power packed that MCQs related to alcohol withdrawal. That means the most common as well as classical sign of alcohol withdrawal is tremor, which happens in 6 to 8 hours. You have to know the chronology for practical purpose as well as for your entrance purpose. And perceptual disturbance. While the person has stopped alcohol use, he can develop hallucinations, auditory hallucinations, visual hallucinations, etc. It develops in 8 to 12 hours. Among that, we have a particular MCQ here, that is Lilliputian hallucinations, which means it is a kind of visual hallucination. The person will be seeing small people. That means you might have read Gulliver in Lilliput, right? That is visual hallucination, Lilliputian hallucination seen in alcohol withdrawal delirium. Next, we have seizure, that means alcohol withdrawal seizure, which occurs in 3% of individuals. And always remember GTCS, that is generalized tonic-clonic seizure. This is a metabolic event, no? So any metabolic event, not even alcohol withdrawal, be it hyponatremia, be it hypoglycemia, all these can cause seizure, right? All such things cause GTCS, generalized tonic-clonic seizure. Never, yeah, of course, Jasil, very good answer. Acute infection, that's a correct answer. 12 to 24 hours. It happens. You have to know the chronology well. And then we have delirium, which is 5% of people will develop delirium. It happens in 72 to 96 hours. There can be slight variations, but for MCQs, you can go with this. And the important thing regarding alcohol withdrawal delirium is we have 10 to 20% mortality that can be asked if untreated. So naturally, the choice of treatment is none other than benzodiazepines. Among that, they will ask like, which is the drug of choice? Chlordiazepoxide. It is a long-acting benzodiazepines. I may be going a bit faster, but don't worry, you will understand whatever I am saying, and thereafter you can revise the workbook. You will know everything in detail. Okay. And chlordiazepoxide, the advantage is it is long-acting, so that less frequent dosing is required. But the problem is many times these alcohol patients will be having liver impairment, right? In that case, it can even precipitate hepatic encephalopathy. So it's not safe in that case. And it has got plenty of drug interactions. So, okay. In such cases, if the liver function is severely impaired, this is a classical MCQ repeatedly asking, even when I was doing my PG entrance examination, these questions were there. They are still asking this. Okay. Ultra short acting temazepam, oxazepam, and midazolam. These drugs can be given. Okay. And we have in practical scenario, we may be using lorazepam, which is a short acting, short to intermediate maximum. Other drugs, non-benzodiazepine drugs, which can be used in alcohol withdrawal is carbamazepine. Going to the next question. A patient presents with high BP, tachycardia, tremors, auditory and visual hallucinations, hepatomegaly, disoriented to time, place, and person. He is mostly suffering from withdrawal of dash, alcohol, cocaine, ketamine, and cannabis. Answers, please. Try to answer in just 10 to 15 seconds. Just make it a practice. So let me move on to the answer is alcohol. So we'll just, if we come back to the question, this is a classical description, right? Autonomic hyperactivity, there is high BP. We have high BP and tachycardia, tremors, auditory and visual hallucination. So this is a straightforward case of alcohol withdrawal delirium. But one other point regarding the other options, cocaine. What is cocaine? It is a stimulant. That means dopamine reuptake inhibitor. Yet another stimulant, that is amphetamine. Okay, the classical MCQ which has been asked multiple times from cocaine is what is cocaine bugs or Magnan symptoms or formication. What is this? This is tactile hallucination. They will come with feeling of, doctor, some insects are crawling under my skin. That is tactile hallucination, also known as cocaine bugs, Magnan symptoms, or formications. Here there is a slight confuser. I'll write here formication. There is yet another, I hope you can read this, yet another thing called flocculation. Flocculation, also known as carphologia. What is that? That is a just like a picking movements seen in delirium. They will have some picking movements in clothes like this. That is flocculation, and this is formication. And flocculation is also known as carphologia. And regarding cannabis withdrawal, always remember cannabis has minimal or no physical dependence or withdrawal symptoms. They can have that psychological, but there is no physical dependence, no or very minimal physical dependence for cannabis. Regarding ketamine or ketamine, its use in psychiatry, this is a recent trend. That means it is used in psychiatry to treat treatment-resistant depression. Intranasal S-ketamine is approved for treatment-resistant depression, but many in our centers also, many centers are giving ketamine as IV infusion. Okay, anyway, remember ketamine like it is used for treatment-resistant depression. Okay, ketamine is very important in the anesthesia faculty. You just refer your anesthesia notes. You can expect questions like all properties of ketamine can be an MCQ. Okay. So next question we have discussed already. A patient of alcohol dependence with deranged LFT comes in withdrawal state. What should be given in his treatment? Options are diazepam, oxazepam, alprazolam, and clonazepam. Shoot your answers, please. This we have discussed already. Okay. And the answer is, we have discussed already. Remember, like Tom, temazepam, oxazepam, and midazolam. Okay. Diazepam, long-acting one. Clonazepam, intermediate. So answer is ultra short-acting, which is oxazepam. A chronic alcohol patient decides to get abstinent. After 3 days, he presents with confusion, disorientation, agitation, and visual hallucinations. What is the diagnosis? Okay, twice they have asked what is the diagnosis. And the options are delirium tremens, Wernicke's encephalopathy, Korsakoff psychosis, alcohol withdrawal seizure. The question is straightforward, but why? Why we have included this question is because to discuss the other options which are important from MCQ point of view. The answer is nothing other than delirium tremens, but we need to discuss the other options also. The first one is Wernicke's encephalopathy. How it is happening? It is due to thiamine deficiency. Thiamine. So thiamine, is the vitamin B1, and the active form of thiamine, that is thiamine pyrophosphate, TPP, thiamine pyrophosphate, that is required in the metabolism. If we take glucose, that first goes to glycolysis, right? Then it goes to TCA cycle. There are many enzymes, and thiamine pyrophosphate is a coenzyme. Okay, without which what happens is that toxic intermediary metabolites accumulate, and that can result in Wernicke's encephalopathy. Okay, the code is GOA. Okay, global confusion, ophthalmoplegia, and ataxia. Global confusion means patient is disoriented, and ophthalmoplegia, sixth nerve mostly. So these are all MCQs. Most common clinical feature of Wernicke's encephalopathy is global confusion. The most specific one and the first one to improve with treatment is nothing other than ophthalmoplegia and ataxia. Ataxia is likely to persist in some patients. And in MRI, the finding is microbleeds in mammillary body. So sometimes they can club all these. This thiamine pyrophosphate, this is from biochemistry, right? They can combine biochemistry, psychiatry, radiology. They may be giving an MRI, and they may be indicating a white lesion, that is hyperintensity in MRI in the area of mammillary body, so that you need to know where this mammillary body is located, right? Okay. Then they will ask what can be the condition, that is Wernicke's encephalopathy. Okay. Remember, triad need not be, this is a practical point. Triad need not be seen in all these triad need not be seen in all patients. Only in 17% of patients the triad will be completely seen. That is Wernicke's encephalopathy. What if it goes untreated? It progresses to something called Korsakoff psychosis. So we have the next question here. Which of the following is a feature of Korsakoff psychosis? And the options are ataxia, amnesia, confusion, and peripheral neuropathy. Can you just type in your answer? Okay. Instead of, yeah, that's it. You have typed the answer, right? Answer is amnesia. So we have discussed Wernicke's encephalopathy, which is GOA, global confusion, ophthalmoplegia, and ataxia. Moving on to the next, Korsakoff psychosis. Regarding Korsakoff psychosis, always remember the first point, that is, this is not a psychosis, it's a misnomer. This is an amnestic syndrome. That means memory is affected. So what kind of amnesia? Amnesia is of two kinds, right? Andrograde as well as retrograde amnesia. What is andrograde amnesia? It means loss of ability to learn new things. Okay, you might have seen our favorite film, that is Gajini, right? Any Surya fans here? Any that Amir Khan fans here? You might have remembered. This is my favorite movie, one of my favorite movies. Gajini, that the character is holding a camera and writing this, no? My friend taking photos because he's not able to learn newer things. That is andrograde amnesia. So in Korsakoff psychosis, andrograde amnesia more than retrograde amnesia. And yet another important thing is confabulation, which means filling up gaps in memory. That means the person is lying, but he is not knowing that he is lying. And if you ask them, where were you in the morning? And they will say, I went to the shop and I bought rice and I had a shake from that shop. That they will say, actually, they don't remember anything. They are filling up the gaps in their memory. That is Korsakoff psychosis. The problem with Korsakoff psychosis is many cases are irreversible. So always in case of alcohol withdrawal, even if the patient is in hypoglycemia, first administer thiamine. Okay, first administer thiamine. Next question. A patient presents with yawning, diarrhea, diaphoresis, mydriasis, fever 104 degree Fahrenheit, rhinorrhea and piloerection. He is most likely suffering from withdrawal of options are alcohol, heroin, ketamine and cannabis. Can you shoot your answers? Okay. The answer is nothing but heroin. Okay, so what are we dealing here? We are dealing with opioid withdrawal, a very important topic for MCQ examinations. Okay, and if you're from Punjab or those areas or northeast of India, this is practically also important for you. But people from south, don't worry, you will also see the opioid epidemic soon. It has already started. Niva Soundararajan Jasil. Okay, heroin, good answer. So regarding opioids, the points you need to know are opioid receptors. They are mu, kappa and delta. Okay, most effects are due to this mu action. Okay, and the next MCQ, most commonly abused opioid, that is heroin, which is diacetyl morphine, also known as brown sugar. Okay, you might have seen this, no, in, if you are a fan of Tamil movies, Iron movie, you might have seen. Okay, then we have yet another MCQ. What is speedball? Speedball is nothing but cocaine plus heroin. The problem with speedball is that mortality risks are high. Okay, then we have short acting. If the opioid is short acting one, the withdrawal will be short but intense. If the opioid he is using is long acting one, the withdrawal will be mild but prolonged. These are the basic concept. Okay, both opioid withdrawal as well as opioid intoxication are MCQs that have summarized. Only this table is required for you. Don't go into the detail. Okay, intoxication, what are the features? Remember, like in intoxication, everything is on the lower side. Okay, you look at the pupil, we have pinpoint pupil. You look at the skin is dry, mucosa is also dry. And what about the bowel and bladder? There is constipation, it's not moving, everything is on the lower side, constipation and urinary retention. And how do people die of opioid intoxication? That is due to respiratory depression. Okay, then other properties, sedation, analgesia and euphoria. So always remember, in intoxication or overdose, everything is on the lower side and person dies due to respiratory depression. Okay, what is the treatment then? Treatment is IV naloxone. Always remember, it is naloxone. They will definitely give the option of naltrexone. It's not naltrexone. You have to give IV naloxone. If it is not there in the option, go for nalmefene. Okay, how long it should be continued? So respiratory depression, no, so continue at least till respiratory rate is more than 12 per minute, and obviously the other cardiorespiratory support that you have to give. Okay, just giving naloxone and neglecting the others won't do. That is understood, right? So this is regarding opioid intoxication or overdose. Okay, kindly comment if my speed is excess in your comment box. Okay, this is because we have to cover maximum points in minimum time. Everything is given in this table. Okay, opioid overdose, everything is on the lower side. Opioid withdrawal, everything is on the higher side. Okay, there is sympathetic overactivity. Just remember this much, everything. And opioid withdrawal, always remember opening of all holes. Okay, opioid withdrawal, opening of all holes. Remember it like this. So all holes, there is leakage. What about the eye? There is mydriasis, there is lacrimation. It dilates and there is leakage, that is lacrimation. In skin, we have diaphoresis, and in bowel and bladder, we have diarrhea. So all holes are open in opioid withdrawal. And we have hyperthermia. That was given in the question, right? Hyperthermia. And sympathetic overactivity, which causes tachycardia, hypertension, and delirium. And two important points there are yawning and something called piloerection. Okay, so this question can specifically, because no other withdrawal causes yawning, alcohol withdrawal no, cannabis withdrawal no, nothing. Okay, yawning is specific for withdrawal of opioid. And we have piloerection. So this appearance is called cold turkey. This has been asked repeatedly. Okay, so what is the treatment of opioid withdrawal? That means for the treatment of alcohol withdrawal, what you are doing, you are substituting it with benzodiazepines. Okay, for the case of opioid withdrawal, you have to substitute it with long-acting opioids, that is methadone maintenance therapy. But in India, we are mostly using something called buprenorphine. You see here, buprenorphine. What is buprenorphine? This is a opioid partial agonist. Okay, and it is a mu partial agonist. When it should be given, suppose a patient is brought to you in opioid withdrawal, are you going to give this thing straight away? No, you should wait for 6 to 8 hours. Okay, otherwise, what is this? That is an partial agonist. No, in presence, it sometimes can act as antagonist, so it can precipitate withdrawal. Always just remember this much: it should be given only 6 to 8 hours after the last dose. And the advantage of buprenorphine is that it has got less abuse potential. That means if you take it beyond a dose, the euphoria does not increase, so abuse potential is less. And the other symptomatic management, we have already said there is sympathetic overactivity, right? So we give clonidine. The patient can have aches and pains. You can treat with NSAIDs, paracetamol, hydration. All those things are important. Okay, and most importantly, remember naltrexone. Naltrexone is an opioid antagonist. It is used in opioid relapse prevention only, not for withdrawal or overdose. And the adverse effect is hepatotoxicity. Since we have discussed naltrexone is an opioid antagonist, but it is used in another area, which is alcohol also. And alcohol, we have anti-craving drugs. Okay, anti-craving drugs. We have acamprosate, naltrexone, as well as something called baclofen. Okay, baclofen is a GABA B agonist, not GABA A. Okay, GABA B agonist. So these are the anti-craving drugs. Alcohol. Remember naltrexone, it has got hepatotoxicity. And one more drug, that is aversive agent. What is that aversive agent? You might have heard about it, disulfiram. If you have done your internship very well, you will be very fluent with disulfiram. Disulfiram is alcohol in our body is converted to acetaldehyde and then to acetic acid. Alcohol, acetaldehyde, and then to acetic acid. The enzyme here is aldehyde dehydrogenase. Disulfiram inhibits this aldehyde dehydrogenase and causes the buildup of acetaldehyde, which causes uncomfortable sensations like nausea, vomiting, hot flushes. And if it is severe, you have taken plenty of amounts of alcohol along with disulfiram, it can even cause death. So you have to get this consent signed. Okay, so acetaldehyde dehydrogenase inhibitor. Always remember, in options they will also give alcohol dehydrogenase inhibitor. It is not, okay, it is not alcohol dehydrogenase inhibitor, it is aldehyde dehydrogenase inhibitor. That is regarding alcohol.